So I never had the fortune of actually ever working with Dr. Hansbrough. He had passed before I came here, but this is the 15th annual John Hansbrough Memorial Lecture. His wife Wendy was sorry that she could not make it. She had a conflict in her schedule. Normally she and his oldest son John try to make this every year. Fortunately this year was not a year they could do this, but we do this every year to honor Dr. Hansbrough, who really did a lot to contribute to the field of burn and burn care. He was born in Virginia in 1946. He graduated from the University of Wisconsin. He was very bright and went to the Harvard Medical School. Did his residency at the University of Colorado, and that's really where he started developing his interest in burn care. He was named the director of burn surgery, the SICU, and emergency medicine. They kind of have a different sort of system that where all this is combined. And eventually he was actually recruited here in 1984 to be the director of the burn center at UCSD. He maintained that position until his death in 2001. Academically, he was very accomplished. In the short time that he was here, he had over 180 peer-reviewed publications, many book chapters, a whole book to himself that you can actually still try and order online on Amazon. And he actually had 3 U.S. patents, one of which was a substance called Transite, which unfortunately is no longer in existence, but there are still some nurses who used to work with this product in our burn unit, and they will tell you that this product was incredible. It was very similar to Epifix, but it's not biologic, and it actually helped a lot of kids heal without having to do any kind of operation on them in the operating room. Unfortunately, a company bought it and then eventually went out of existence, so it's not here anymore, but it's one of those products that, had it taken off, probably would still be on the forefront of burn care today. He trained 17 fellows in burn surgery. He had many research grants during the time that he was here. He was invited nationally and internationally to do presentations. He had many, one of his big things that he liked to do was education. He provided it both in person and on CD. He did a lot of training to pre-hospital folks, people here at UCSD, and he also did a lot of work with the military, kind of getting people prepped for when they were going to be deployed. His research projects were numerous. This is just a handful of the things that he worked on. He was actually one of the first that talked about early feeding in the burn patients, which we all know now is very important in the care of these guys. They are super metabolic, and if you don't feed them early enough, they actually can have a lot of consequences of that. He also worked on pentoxifylline. He's one of the first people to actually kind of look at this substrate for shock. And it's actually in our lab, and there are some projects that every once in a while mention pentoxifylline, although they're not doing as much work with it as they used to. These were just another pull, and you can see a lot of the things that he worked on are actually things that we still use today. Collagenase, fibrin glue, these are all things that we still continue to work on and work with. But unfortunately, and Wendy asked me to talk about this part of his life, especially in light of recent events. On March 7, 2001, Dr. Hansbrough took his own life. I don't know how many of you are aware of that. He suffered from depression, had a major depressive episode about 15 years before he died. And on March 7th, Wendy got a phone call. He wasn't home, and found out that he had actually passed away. Because of
Hansbrough's story illustrates the complex interplay of personal and cultural factors at work in this issue. It also shows that the impact from even one physician's death can be profound.
It's a huge loss. I just, thank God every day that I was in the area that I was, to be at that hospital with Dr. Hansbrough, because I know I would have not got the same care and treatment that I got there.
John was brilliant. He contributed a lot to literature and to knowledge, as well as to his patients. And it was his passion. And so when he died, they lost a physician with a passion for taking care of those patients.
So because of his untimely death, Wendy and her son actually have become very involved in suicide prevention, both locally and nationally. And she really wanted to speak on this, especially in light of the 2 recent suicides that happened, very public deaths that have happened. This was actually a meta-analysis that came out in the American Journal of Psychiatry in 2004. And they looked at a bunch of studies that looked at suicide rates amongst physicians. And what they found was that the suicide rate among male physicians is 1.4 times that of the rest of the population. Women, it's higher. It's up to 2.27, and there's actually some studies that quote it to be about 4 to 5 times higher than the general population. The prevalence of depression amongst residents is actually higher than similarly aged individuals in the general population. There's a slew of reasons for why that's the case. In 2003, partly because of Dr. Hansbrough's death, but because of other events, there was a consensus statement put out by JAMA. Wendy Hansbrough was actually on this panel. And if you want to find it, it's called Confronting Depression and Suicide in Physicians. And what they finally concluded after this 2-day-long meeting was a couple things. One is that they recommend transforming professional attitudes and changing institutional policies to encourage physicians to seek help. Because in a lot of places, there's still quite a stigma against depression and seeking psychological and psychiatric help. As barriers are removed and physicians confront depression and suicidality in their peers, they are actually more likely to recognize and treat these conditions in patients, colleagues, and medical students. So not only do you get better at helping yourself, but you actually get better at helping everyone else around you. So what can you do? One is that it's always good to have personal health care, whether or not it be your primary care doctor or a psychologist or a psychiatrist if that's what you need. Learn to recognize suicidality and depression. It's not just about being sad. There's more components to depression than just someone being sad. We all get sad. That alone is not depression. And utilize physician resources. So there actually are resources at UCSD, in case you did not know. There is an employee assistance program that is available to anyone that works at UCSD. They are open 24/7. There is a phone number that you can call. And what they actually provide is support for any kind of predictable or unpredictable crisis that may occur in your life. This is just a handful of the things that they can help you deal with. There's actually a whole long 24-page pamphlet that goes over all the services that they provide, but this is just a handful of the things that they've had people come to them for help with. Again, there's a slew of services that they are able to provide. It's not just mental, also physical, and they, again, are 24/7. It is completely not necessarily anonymous, but it is private. They will not release your information to anybody. The only instance in which it may get released is if you are a danger to someone else. So that's the one time where it might be reported, but other than that, anything that you disclose to them is completely confidential. So I encourage you, for anyone who is interested or is even curious, to just call them, find out what they have if you just want to know what services they have. But they are available, and for, like I said, for any UCSD employee. So with that being said, again, we are here not necessarily to celebrate his death, but to celebrate his life. Dr. Hansbrough, again, was very big on education, so we do this lecture to continue that legacy that he started of educating people. So with that, I'm very pleased to present Dr. Chung. Dr. Chung is very well known in the burn community. He's currently the second vice president for the American Burn Association, which is our organization for burn surgeons, and actually all of burn care. It's not just burn surgeons, it's all the intensivists, pre-hospital, paramedics, firefighters, OT, PT. It's basically everybody that's part of the burn team. He's currently the chief of medicine at the San Antonio Military Medical Center in Fort Sam Houston, Texas. However, his new job is actually going to be in mid-July. He is actually going to be the chief of medicine at the United States Military Academy, at the where is it? Uniformed Services University in Bethesda, Maryland. So this is a much bigger position. He's actually in charge of not just his program, but anywhere that his students go to. So he actually has to go do site visits at places around the country, including Balboa. So he actually may be back in town, and we've offered to give him his little burn fix when he's back in the area. So again, he has numerous publications, many book chapters. Actually won an award in 2009 from the Army because of a device that he had and a protocol that he had developed for burn care. It was a New Innovations Award that he had received, which is a big deal in the military community. So again, please welcome Dr. Chung, and we look forward to hearing your talk.
All right, Dr. Clary, Dr. Lee, thank you very much for this invitation. Goes without saying, it's a tremendous honor to be here, to be invited to talk for the Hansbrough Lecture. I think if you were to be looking down right now, I'd be very proud that his legacy lives and is even thriving. The Burn Center is just a spectacular legacy that that continues to excel. This morning, I was struck by how well-dressed everyone was. This is probably the most well-dressed Department of Surgery I've ever seen. But then I realized it's picture day. So, I guess that's, usually you're probably in scrubs, right? So, so this is my topic. I'm here in my personal capacity, and I don't have any financial interests or conflicts. This is where I work. Used to be called Brooke Army Medical Center. We're sort of going through an identity crisis. Some people now call it San Antonio Military Medical Center. Some still prefer to call it BAMC. But within Brooke Army Medical Center, or SAMC, is the Institute of Surgical Research. And that is the burn center for the DoD. We serve the entire South Texas region, as well as caring for combat casualties and military burns from around the world, and have about 800 admissions a year. And this is where, after fellowship, I didn't volunteer to come here. I was told by the Army, you're going to the Army Burn Center. Much like any other assignment, that's what happens in the military if you join. What I want to do is start out by trying to convince this group that there's a lot of similarities in terms of the host response, the human host response to trauma and burn. And this is a concept that Dr. Pruitt really advocated for decades ago. Dr. Pruitt, as you know, is considered one of the fathers of burn care and trauma, and is still a fixture in our burn center and attends many conferences on a weekly basis. And so he sort of introduced this idea that burns is the universal trauma model. The host response to burn is similar, it's augmented, but similar to that of multi-trauma and tissue destruction that occurs as a result. Well, it wasn't validated, this concept, until this study came out. This study was a large, well-funded NIH study called the Blue Grant, where they enrolled a number of different categories of patients to include burn, trauma. And the topic, and this got a lot of press when it first came out in the proceedings, and the topic in the news was about how the genomic response in mice was a poor example of the human inflammatory condition. However, embedded, and there was a second message embedded into this study where they determined that inflammatory stressors from different etiologies result in highly similar genomic responses in humans. If you look at the genetic expression of humans in different conditions, this is burns, as you can see, augmented and over time sustained. This is trauma. And this is simulated sepsis, so human endotoxemia. They took a bunch of human volunteers, injected them with endotoxin, and observed them for a period of time. Probably medical student volunteers. I would not recommend this if you're thinking about this, but it just goes to show you that sudden inflammatory response is in the same direction and very strongly correlated with other conditions. And here's the R squared. Human burn is nearly identical. R squared of 0.9 is really unheard of. It just means that it's pretty similar. And then this simulated sepsis of 0.47, which was significant, not as closely correlated, but like I said, it's a simulated scenario. And I think if you think about patients who develop sepsis, it probably would be more correlated with human burn and actual trauma. And so, one of the co-authors of this paper, lead authors, stated, if researchers can find a drug or a therapy that works for one of those conditions in people, it might work for all three. So what I want to impress upon this group is that the principles I discuss in the management of critical care of burns, you could extrapolate to any other condition where patients get ill. So post-surgical patients, trauma patients, et cetera, and even septic patients, medical patients. And so that's the principle. Those principles hold true across many patient categories, the host response to injury. And so I want to start out by sort of talking about the priorities in burn care. I've been doing burns only for 13 years, but something I've learned as a medical intensivist, as you know, I'm not a surgeon. I'm looking at it from a different lens. From a medical intensivist, what I've learned over time is that it's all about the wounds. If the wounds don't heal, the patient's not going to do well, no matter what we have available as a therapeutic in the ICU. And so that's really the priority. Get the burn off, apply autograft definitive coverage with their own skin. That's all we have for definitive coverage at the moment. And then try to optimize the conditions of wound healing. And this is the result that you expect in somebody that's going to survive. And so if you think about other types of injury or insults, whether it's surgery, major surgery, or sepsis or trauma, this paradigm of the injury results in an inflammatory response. There's some type of SIRS process that goes on, so systemic inflammatory response as a result of that insult, and the patients may develop organ failure and die from that organ failure, or through some aggressive support can recover. And fortunately, most patients do recover. This happens maybe once, twice, if they're unlucky. In burns, this happens over and over and over again. Just consider the burn itself as a tremendous insult. The resuscitation that they receive, upwards of 20 to 30 liters in the first 24 hours, is another insult. And then the excisional surgery, the surgery that occurs where the dead skin has to come off, that's a 3 to 4 liter blood loss for a 50% burn. That's the entire blood exchange. That's another insult. And then if they have an inhalation injury or just from their burns, they're going to get some type of infectious complication. And so this cycle happens over and over again. And each time the host mounts this severe and profound inflammatory response that sometimes is dysregulated, and over time you just become immune suppressed and you die of something as common as a bread mold. This is an unfortunate case of a patient, 24-year-old female who was refueling a generator and died after suffering 40% burn. After their first surgery, all the autograft fell off and all her donor sites converted, and we just had very few options over time. And after about 7 episodes of sepsis, she died of an invasive fungal wound infection. This concept of the host response being dysregulated and profound with each insult is something that's well described in the literature. This is work from Dr. Jeske and Dr. Herndon, where they describe in children, they observe that if you use just IL-6 as a marker of inflammation, every time they take the patients to the OR, there's a spike in IL-6. And we observe this in the clinic, in the ICU, where patients come back after a big excision or debridement on pressors for a short period of time, and they're just physiologically and metabolically deranged for a little while. This is something we see very often. And so Dr. Wolf, who was our burn director for a while and trained me as a burn intensivist, used to always say during rounds, it's a race against time to get the burn wounds closed. Until the burn wound is closed, the patient will be at risk for death. And so this is a concept that has been seared in my mind as an intensivist. And this concept could be true for any other patient condition where you're relying on healing, wound healing, such as trauma or major surgery. And so the principles that I adhere to, we're not looking for the silver bullet. It doesn't exist in the ICU. What we're sort of looking through, or how we're looking at this problem, is we're just trying to provide a shield. We're trying to optimize the conditions of wound healing and protect patients from various complications that can occur throughout an entire hospitalization. And so these are the things that we do in the ICU to optimize that condition, the conditions of wound healing. And this is how I approach every patient who's post-surgical and every patient who's a trauma victim or a burn victim. How do you optimize the conditions of wound healing, and what can we do to sustain life as they heal? Okay, it starts with the resuscitation. I told you that that's an insult in and of itself, and there are ways to mitigate this. As you probably know, this group is probably very well versed in burn shock and the pathophysiology of burn shock, but there's tremendous capillary leak, as you know, in both unburned and burned tissue, and it results in a profound hypovolemia followed by a distributive shock because of the host response to that injury. It's this dysregulated host response with a dysregulated immune inflammatory response. And so the ABA published this clinical practice guidelines. Over years, there have been many different resuscitation formulas, and they got together and wrote this summary article, which is still used. It was published in 2008. And what they wrote is the common formulas used to initiate resuscitation should estimate anywhere from 2, the modified Brooke, to 4 cc's per kg per TBSA in the first 24 hours. And so this is the traditional formulas that are widely used, and I'm sure you guys, when you encounter a big burn, this is one of the first things that you do. You calculate, you jot down the initial fluid rate that you're going to be giving. You do this formula, and then you divide by 2, and then divide by 8, and voila, you have your initial fluid rate. How many providers, though, are really using this formula that's not in burn care? We tried to answer or address this question in our own community and took patients that were brought in from the community via ambulance to our burn center and looked at how much fluid they had received up to that point and did the backwards calculation and asked, well, what fluid, what resuscitation formula would they have used to derive that initial rate? So it's a little backwards calculation. And if they were using the modified Brooke, that they would be along this bottom red line. If they were using the Parkland, they would be in this top red line. And you can see the dots are all over the place. It's clear that EMS providers and non-burn providers are not using any formula. They're just starting fluids, hanging a bolus, a bag of fluid, and just starting it wide open. That's pretty clear. Okay, and if you ask why, it's because the formula and the way you derive the initial fluid rate is complicated. Why go through that 3-step process when you can just hang the bag of fluid? And so we know that non-burn providers are not using any formula. But does it really matter where you start? Whether it's 2 or 4, that's a big difference in fluid rate. You're talking about double the fluid rate, between 500 to a liter in some cases. And so we asked the question, does the starting rate really matter? And it just so happened that I know Dr. Wolf was here a few years ago, and he talked about the burn flow sheet. And so we made our entire system, the trauma system in the military, use a burn flow sheet to document their resuscitation so that folks, as they handed off patients, could know how much fluids the burn patients received during their global evacuation. And so what that resulted in is a wealth of data, a bunch of burn flow sheets that we can analyze. And what we found, interestingly enough, that without any guidance, we just said any 2 to 4 would be fine, half the patients started their initial fluid resuscitation using with an initial fluid rate derived by the modified Brooke, and another cohort derived their initial fluid rate using the Parkland. So it's like a randomized control trial, accidental randomized control trial. And we looked at this retrospectively, obviously, but if you start at 2 to derive your initial fluid rate, you're going to end up with a 4 cc resus. If you start at 4, you're going to end with a 6 cc resus. And this is pretty consistent with what's published in the literature. And so we titled this manuscript, Fluid Begets Fluid. The higher you start, the higher you'll end up. And so at the end of the day, though, these complicated formulas, it's not too complicated, but these formulas are really designed to help you derive that starting rate. Everybody knows that once you start your fluid rate, you don't arbitrarily decrease the fluids by half at the 8-hour mark. It's nothing magic happens at the 8-hour mark where they all of a sudden need half their fluid rate, as the Parkland and the modified Brooke predict. You want to get there, but you apply basic critical care principles in practice and in real life to titrate the fluid slowly up and down based on what the patient's giving you. And so that's what we do. So why go through that, the multi-step process to derive the fluid rate, when hopefully a simpler way of deriving that fluid rate exists. And so that's why we came up with the rule of 10. A simpler way of deriving that initial fluid rate. Okay, so you basically estimate the burn size using the rule of 9s to the nearest 10, and then multiply that by 10. That's it. Okay, and we looked at this in simulated patients, 100,000 simulated patients, and really it applies for nearly all patients. And the patients that doesn't apply for, these are patients that are going to die anyway, and these are patients that really doesn't matter where you start. And so you could see if you had 4 patients simultaneously come in, 30% burn, 40% burn, 70% burn, times by 10, and you start that initial fluid rate. It works. And once you start that rate, where you start really doesn't matter, as we sort of discussed, although there's that, the higher you start, the higher you'll end up. But once you start that rate, whatever it is, apply basic critical care principles. You use a compilation of various endpoints that you use every day in the ICU and titrate the rate carefully up and down at the bedside. And this is done a lot by the nurses and physicians working together to optimally resuscitate the fluid. This concept, this rule of 10, is something that we've adopted in the military, and we're using to teach our pre-hospital providers and deployed providers, so it's in the PTLS, the military version. We're trying to get it into the ABA and ATLS. The community is still a little bit resistant. But I did find this blog, so it's hit the mainstream. A lot of emergency medicine providers love this formula, and it's simple because of its simplicity. And this is something that is starting to catch on, so rule of 10. So once you start the resuscitation, the principles that we all adhere to, those of us who do this a lot, try to, if you try to achieve normal blood pressure and euvolemia, and apply the same strategy of resuscitation that you apply for other patients, you may run into trouble. So being tolerant of hypotension, relative hypotension, in a MAP of 50 is okay. CVP doesn't have to be 8 or 12. Run them a little dry, because any attempts to try to get them normal, you'll get into trouble. And so this concept of getting into trouble or over-resuscitation is something that our group has written a lot about, resuscitation morbidity. You can get eschar syndrome, obviously. Thoracic eschar syndrome is a problem that's under-recognized. You can get compartment syndrome and then orbital compartment syndrome as well. And so these patients, after about 20 liters of fluid, if their intraocular pressures are above 20, they need canthotomies. The bigger problem, or the biggest problem in burns that we've encountered, is abdominal compartment syndrome. This is nearly fatal. If you have a big burn and you combine that with the insult and the subsequent metabolic derangements that you'll see with an open abdomen, and trying to manage that, it's just too much for the body to handle. And so most of those patients don't live. Yes, there are case reports of 70%ers with open abdomen after resuscitation somehow surviving, but that is the exception rather than the rule. And so how do you know when you're starting to get into trouble? We call it a runaway resuscitation. And so there's a metric that we all use, or many of us use in the burn community, and as I go around, I'm on the verification committee for the ABA, and as we go around, we ask a lot of burn centers, hey, how do you QC your burn resuscitation? Any good burn center will QC their burn resuscitations, and after a big resus, discuss it as a multi-D group, and then figure out what they did right, what they could improve, and then try to improve the next time. Because it doesn't happen every day. It's not, in most burn centers, it's 1 or 2 big burns a month. And so one number that we use, we obviously can use the traditional formula number, so 2 to 4, did they get a 6 cc resus or a 4 cc resus? Another metric you can use is the Ivy index. So Dr. Ivy wrote a paper published in the journal Trauma, where the group took 10 patients and measured intra-abdominal pressures and correlated 250 cc's per kg in a 24-hour period, anything above that with intra-abdominal hypertension, and hence was born the IV index. And so anybody who you think is going to receive 250 cc's, greater than 250 cc's per kg in a 24-hour period, you can predict that at any point in the first 24 hours as you project. Let's say I continue my fluid rate at a liter an hour, it's hour 13, extrapolate up for 24 hours, is that above 250 cc's? You got to do something. Okay, that's the IV index. Yes, 10 patients is all it took for somebody to get something named after them. That's pretty remarkable. And so you can also use the traditional formulas, the number, as I alluded to. And so what do you do when you encounter a runaway resuscitation? The runaway resuscitation can, you can, burn experts, people that do this all the time, they know it's like a spidey sense. It's not really, because the patient's telling you that they're in trouble, but zero urine output for a couple of hours in a row, over a liter already on the LR, and they're on 3 pressors or something like that. And that's the runaway resuscitation, and that could be happening at hour 6, it can happen at hour 13. So what do you do? What can you do? Well, albumin has been something that's been advocated, FFP. There are some that use hypertonic saline. I know you guys here use FFP, and I'll show you a study that really supports that. And then there are some centers that are using a lot of vitamin C. We're not talking the Merrick dose. We're talking, 6 grams an hour. That's a lot, way above the recommended daily allowance. But vitamin C at those high doses have been shown to decrease fluid rates. This is the Tanaka study, one randomized control trial. This needs to be replicated. And then there are many centers that are using plasma exchange for cytokine removal and also CVVH for metabolic control. And so these are all the adjuncts that you can use. So just to sort of give you an argument for or support for FFP, we have a nice rat study, a nice hemorrhage model where we look at endothelium, so looking at glycocalyx, endothelial glycocalyx. And so you're looking at the capillaries and after hemorrhage and resuscitation. And so we bled rats, 40% hemorrhage, and then resuscitated them with normal saline, LR, albumin, and colloid, so FFP, 4 groups, and looked at what happened to the endothelium and glycocalyx. So we measured syndican-1, which is shedding of glycocalyx, and everything lined up. And so what we observed is this is a 40% burn with no resuscitation. Actually, this is sham, no hemorrhage. And so you can see the glycocalyx is around 0.6, the thickness. With saline, they did the worst. Okay, so glycocalyx completely sheds, and you get massive capillary leak. This happens with LR too. Albumin, much less so. But look at FFP. Completely preserves the endothelial glycocalyx. Just food for thought. It's something that is catching on around the burn community. Dr. Hansbrough really, was one of the innovators in this area, and I know a lot of burn centers in the country are starting to catch on and starting to use FFP much earlier. And we, in our burn center, we use a combination of albumin and FFP, but I know that my colleagues are starting to use more and more FFP. But this is why. Okay, so optimal resuscitation requires you're trying to maintain organ perfusion using basic critical care principles, and you're doing so at the least physiologic cost. Whatever you tolerate as a MAP for normal patients, lower it by 10. If you shoot for a MAP of 60 usually, or 65, be okay with a MAP of 55, because if you try to normalize them, you're going to over-resuscitate. Okay, so organ support. This is organ failure is a topic that's near and dear to my heart because that's what I do. That's my specialty. But it's something that we've sort of written a lot about in the literature. And so we'll go through that. So acute kidney injury and burns, as you may know, there are multiple staging criteria now. So rifle, you're probably aware of, Aiken criteria. There's actually a new one called the KDIGO criteria, published in 2012. I just can't keep up with all these different criteria and try to, validate each one. So we stopped at Aiken. Anyway, so this is Aiken, and what we found in our burn patients when we pooled civilians and military together, there was about a 33% prevalence amongst those that came in through the door with burns. And you can see if you developed AKI, ICU, hospital lengths of stay, and mortality is just significantly different. Do small changes matter? Dr. Pruitt, in his seminar diatribes said, it doesn't matter if you have Aiken 1. Well, we looked at this, and when you compare Aiken stage 1 versus no AKI, there's a dramatic increase. It's not big, but it's also different and more precise than the rifle criteria. So if you're using any criteria to stage your AKI, you should probably be using Aiken, and I would argue KD goes probably better. But generally, a 0.3 increase in a 48-hour period is stage 1. Doubling is stage 2. Tripling is stage 3. Pretty simple. There's a urine output criteria, but just use the creatinine and you'll be fine. So as you go up higher in the stage, obviously the mortality increases. And historically, patients who are burned and then subsequently develop renal failure or AKI, severe enough to require renal replacement therapy, mortality has been tremendous, like 90% to 100%. That's what's reported in the literature before 2000. This is the Best Kidney Study, which is the general ICU population, a 30,000 patient observational study that was published in JAMA. So this is just for comparison, but this is burns right here. 90% if they develop AKI requiring renal replacement therapy. So this is not acceptable to anybody who is taking care of burns and on a regular basis. And so one of the things that Dr. Holcomb, who was the ISR commander, who basically brought me to the ISR, my first meeting, he basically directed me or ordered me to start a renal replacement therapy program. And I think it's they had many conflicts with nephrology, their nephrology colleagues there. They just didn't see eye to eye, and so we decided to start our own program. And so after starting our own program, fast forward, we looked at our data. When you do something new, you want to be able to evaluate it and then report it in the literature so that you can, generalize your results and generalize your experience. And so what we did was we took the patients that we treated. We decided our platform and our main therapy would be CVVH, so hemofiltration, not dialysis, which is a little bit different. That's a whole nother lecture, but CVVH compared to a historical control. And so you can see that the two groups, after we started this program, relatively different in age, but same TBSA, no difference, no difference in Aiken stage, and then you can see pretty well matched, as well as you can match sort of this type of cohort study. And what we saw was a dramatic improvement in survival in the patients that received CVVH. And what's interesting is of the patients in the control group, only 2 received some form of renal replacement therapy. And so it used to be the pattern where we would consult nephrology, they would scratch their heads and give us it's pre-renal, intrarenal, and avoid nephrotoxins, trial Lasix, the usual recommendations, and not do anything about it. And so it was frustrating, and a patient does not meet criteria for dialysis. Of course, these patients are sick, metabolically deranged, but you can't apply outpatient dialysis criteria to very sick inpatients. It's just impossible. If you try to do that, they all die. And by the time they don't have time to meet those criteria, they'll die before meeting those AEIOU traditional criteria. Okay? And so compared to aggressive renal replacement therapy, you can see the 28-day mortality, huge difference, and then in-hospital mortality, big difference. Number needed to treat of 3 to 4. A number needed to treat that big, you got to be really suspicious of. So I got a lot of people scratching their heads and looking at me like I had 2 heads when I presented these data. And obviously, people were like, "Well, you need to do a randomized controlled trial," and so we did. before I go into that. So when you look at patients on pressors, so what was interesting is people, the nephrology community would say, hey, you know, if you put somebody on CRT when they're hemodynamically unstable, that's a problem. You're gonna run into problems and you're gonna kill patients. Well, not only did we not kill patients, but they got better, interestingly enough, at a relatively high dose of therapy, hemofiltration. And their ARDS got better. And this is, we're not removing a ton of fluid when they're initially getting started on CRT. We're just running them euvolemic, and still their ARDS get better. So that was interesting, and this is the basis of a randomized controlled trial. This took 8 years to perform. It was among the hardest things I've ever done, but finally we got it across the finish line. But we took this concept of higher dose hemofiltration and applied it in the sickest of the sick. We tried to isolate just septic shock and try to look at it from that lens, but that required a IDE, and that increased the budget, the planned budget by threefold, so $8 million study. We didn't have $8 million. And so we decided to just increase the threshold, so septic shock with AKI. And so these are the inclusion criteria. So they had to have AKI. That was a requirement by the FDA, or else we're using it off-label, and so that's why the IDE, the investigational device exemption, that's just laborious and a huge obstacle, and so we couldn't do that. So this was problematic because that decreased our sample size significantly, and we had trouble enrolling, but we'll talk about that in a second. So once criteria was met in these burn patients, the sickest of the sick, they were placed on high volume hemofiltration, so high dose hemofiltration versus a wild type control. So whatever the center decided to was their standard of care, and I assume that many of them would not get renal replacement therapy, but interestingly enough, all of them did. But this is high volume hemofiltration at CVVH mode, like I said, a different mode than hemodialysis, at 70 cc's per kg per hour for a 48-hour period. And so 70 cc's means, like, if you do standard CVVH, you're going at 2 liters an hour as a dose. You would basically triple that. Okay. We use as our primary endpoint an index, vasopressor dependency index, which is adding up normalizing all the different pressors that you use in practice, so epinephrine, levofed, vasopressin, adding them together and then indexing it to MAP, because everybody titrates their drug to a different MAP, and so there's variability in practice. So we corrected for that with the vasopressor dependency index, and we looked at various endpoints. And so this is our flow diagram. You can see how troubling, this was. 4,000 screen, only 96 eligible, barely 37 enrolled, and we were able to, this is intent to treat, but we were able to analyze for our primary endpoint 12 versus 21. Not groundbreaking, and it's not going to, convince, it's not New England Journal material, but this is, study like this hasn't been done before, and probably won't get done because it's so dang expensive, excuse me, and so it's just, you could tell I have PTSD from trying to do this trial. It's just very hard. So this is the age, so age difference, no age difference, gender, TBSA, ISS. These are all civilian patients, by the way. About half of them, more than half of them had ARDS and Apache score. These are the physiologic variables at the time they were randomized and initiated on therapy to BUN. This is lower than what you would think, but that's because it took us 24 hours to get consent in some cases, and so during that period they were getting some form of therapy, many of them, and so that's why, and that's the same reason for the pH. As you can see, of the control 12 subjects, they all got some form of renal replacement therapy, which was surprising, but we let that happen, compared to 70 cc's in the treatment arm. So clearly a departure or separation in dose, which was good. However, I did not expect to see any difference in anything, because this is such a small sample size, and this was originally powered for 120 patients, and we barely got 37. So these are the physiologic variables at 24 hours. The only thing that was different was they had better metabolic control. B1's better. These guys were in the control at 24 hours, were just sort of still metabolically deranged, and then at 48 hours, same thing. Okay. This is our primary endpoint. Probably, box plot isn't that dramatic. You can see very small numbers. However, this was significant, which was very surprising to us. And when we look at proportions of those that were on pressors, you see the same chart that you saw in our retrospective study. So just food for thought. When we looked at cytokines, I thought, oh wow, this is going to be awesome. We're going to demonstrate some type of mechanism, the cytokine removal. This is going to be awesome. So we measured IL-6, IL-8, IL-10 over a 48-hour period. No difference whatsoever. It's not cytokine removal that's resulting in this hemodynamic response. It's analogous to, when you have a cytokine storm in a burn patient, it's analogous to you trying to mop a pool. Yeah, you're going to get some water out, ring, mop, pool, but, consider a pool with the faucet on, and you're trying to mop the pool, you'll never make a dent, okay? You got to shut off the faucet. And really, that's how I've changed my thinking in terms of taking care of these patients. When you look at MOD scores, so organ failure scores over time, the high-volume hemofiltration group improved significantly while the control did not. And this is mortality. This was not powered for mortality, so you can see there's no difference. And so our conclusion for this paper, just published last in November, high-volume hemofiltration was effective in reversing shock and improving organ function in burn patients with the combination of septic shock and AKI, and it's safe. This idea that high-volume or high-dose hemofiltration could be harmful, this is the second study. There was another large randomized control trial that showed that in the general population it didn't really impact mortality, but it's safe. Whether reversal of shock in these patients can improve survival is yet to be determined. You can make the argument, well, you treated the shock and you shortened the duration of shock and the duration that the patient was on pressors. Does that matter? Well, if you think about it, I told you in the beginning of this talk that, my job and our job in the ICU is to improve or optimize the conditions of wound healing. Well, what happens when the patient is on 3 pressors? Is wound healing occurring at the capillary level? So it just makes sense. You shorten the duration of pressors, you're probably doing some good. So that's my stance, and we can argue, but I think that's probably rational. And until somebody can replicate the study, I think this shows that you can potentially help somebody who's on multiple pressors and really, really metabolically deranged. And so because we had such a hard time enrolling patients, I was on BID, Prilosec, and so we decided about 2 years into it, after going through some therapy, to launch a randomized controlled trial, because these patients were not getting enrolled into our trial because of one or two exclusion criteria. And so we decided, well, all these patients are going on renal replacement therapy. We need to know what's going on with them. And so we quickly, in a 2-week period, wrote up an observational study and decided to run it concurrently with our interventional study. So among the participating centers, if they went on renal replacement therapy but not enrolled into we called it the rescue trial, they were enrolled in this study. So this was a good, mitigating strategy. And so we got 170 patients, so a little bit better, and something that can inform the community. This paper was just accepted in Journal of Burn Care. I was, by contract, obligated to submit it into Journal of Burn Care, and Dr. Herndon finally accepted it after 6 months of going back and forth. That was painful too. But anyway, so this is the age. You could see gender about the same, TBSA, full thickness. Sorry, Dr. Herndon, if you're watching. ISS, Apache, and then this is the expected mortality of this patient population. So this is a descriptive study, so let's see what we observed. Among the centers that do this all the time, Dr. Lee wanted to participate in this study, but for some reason there was a disconnect. It would have been, I'm sure you would have contributed a ton of patients and same results. But so this is the Aiken stage when patients went on. So you can see that there are some patients that don't even have AKI going on renal replacement therapy. Well, Why is that? Well, it's because they have another reason to go on renal replacement therapy, whether it's massive fluid overload or shock. They don't have to have AKI to go on renal replacement therapy. You can use other things, other endpoints, you can try to fix other problems. If somebody's 30 liters positive and they're weeping through their wounds and they're not making any urine, they're irresponsive, not responsive to Lasix, and you're trying to heal their wounds, it's okay to put them on renal replacement therapy. Okay, so this is the physiologic variables, the chemistries. You can see BUN's about the same this is at initiation. So the burn community in general, when it comes to renal replacement therapy, very aggressive. This is the blood flow, treatment duration, about 2 weeks on average. How do we anticoagulate the circuit? I used to be very nervous about heparin, and so when we started our program, we were doing citrate anticoagulation, binds the calcium and keeps the circuit from clotting, just like blood. Right? Blood has citrate in it, as you know. And so we use citrate primarily, but then we ran out of citrate. All the drug shortages that occur, we ran out of citrate. And so we were forced to use heparin. And patients didn't bleed to death. And so we got some experience with heparin. And so you can see about a third received heparin in the burn community, citrate, and then some got none. No anticoagulation, which I don't know how they achieved that, but they did. So initial mode, looking at what mode they're going on. So I know this is not a nephrology group, but CVVH is the hemofiltration I was talking about, is different from HD and HDF in terms of the way it clears solutes, and then intermittent hemodialysis. So more than half the patients got CVVH as their preferred. And so I wondered, is there a difference in outcome between the different modes? Because if you're a nephrologist, you're probably going to do CVVHD. It's very unusual for a nephrologist to adopt hemofiltration because it's imprecise. Everything goes low. For me, that's simpler. Everything goes low, you replace it. It's simpler. And so is there a difference between the three different strategies? This is CVVHDF is a combination of hemofiltration and dialysis. And you can see there's not a lot of separation, maybe, but if you look at just the patients in shock, it's even closer. And then when you combine CVVHD and HDF in the same population, there's actually a significant difference. So I think CVVH, there's something to CVVH in the burn population as a preferred modality. Okay, that's another paper that we're working on. So overall, hospital mortality was 50%, less than predicted. I told you, historically, 90% mortality. So we're down to 50%. This is a big win for the burn community. Need for renal replacement therapy, there's a question that we asked. How many of the survivors, how many stay on renal replacement therapy and need long-term dialysis? That's a problem, right? If you survive the burn and you're on dialysis, needing dialysis 3 times a week, that's a problem. So what we observed is 1 out of every 5 survivors needed some form of renal replacement therapy if they went on and survived. And at 6 months, half of those patients got better. And so only 1 out of every 10 patients who survive renal replacement therapy and their injury need longer-term dialysis. And I bet you if we looked out even further, those patients would eventually recover their renal function. And so the bottom line of this effort is timely initiation of RT with an individualized preference to continuous modes, and I would argue CVVH, at relatively higher doses than normal. Has become standard practice in burns with AKI and is associated with a historical mortality. This is the bottom line. This is what we observed. And so this concept of using higher doses, I think you should individualize your dose. If your pH is 6.9, your K is 6, your BUN's 100, you're not going to start with 1 liter an hour. Put them on a higher dose. Treat the patient. Applying standard doses for all patients, regardless of how metabolically deranged, is probably the wrong approach, and I think the nephrology community is catching up. Okay, moving on to inhalation injury. As you know, this is a big problem in the burn community. Inhalation injury or smoke inhalation injury is not a thermal problem. As you know, it's a chemical problem. The products of combustion depositing in the tracheobronchial epithelium, the pseudocolumnar cells with the cilia, they're all decimated, okay? And your ability to bring up mucus is damaged. And not only that, you're hypersecreting, these are goblet cells that are just exploding, mucus overproduction. And so you're like basically treating a cystic fibrosis patient in the more severe cases. And so this is what we're dealing with. This is an example of a patient that was in a house fire. You can't get smoke inhalation injury in generally when you're outside. It's got to be inside, enclosed space, breathing in and out the toxic fumes, a thick smoke, and that's real, true smoke inhalation injury. And so this is a case like that, where the patient was found down in the house fire, breathing in and out this toxic, products of combustion. This carbonaceous soot deposited throughout the tracheobronchial tree, damaging already the tracheobronchial mucosa. And you can see, after multiple bronchs, this is day 3, the mucosa is transforming. Lots of secretions during this time. This is why physiotherapy, we use heparin to try to prevent clot, because fibrinaceous clot is a problem in these patients. And then day 10, these patients invariably will get some type of pneumonia at some point because they have no protective mechanism. So it's guaranteed that they're going to get a pneumonia. It's a matter of when. And so, we don't like to call it VAP. It's not ventilator associated or ventilator induced. It's inhalation related. So we got to do something with that definition. Anyway, so in terms of the strategy, ventilatory strategy, I've over time have evolved in my thinking. I used to be all about APRV, and then I came to the ISR and they used high frequency. And now I'm just, I think any vent mode that you're good at, you should try to use, and it's going to work. One ventilator mode is not going to be better than another ventilator mode. I don't think we'll ever see a study that shows a difference. However, in the burn center, this is something that we use, the high frequency percussive ventilator. It's different than the oscillator, okay? This is not the oscillator, it's the high frequency percussive HFPV, which is a little bit different in that you're basically taking subtidal volumes, so short bursts of breaths, and stacking them on top of each other. And what that does is it creates sort of this bidirectional flow. So imagine high frequency superimposed over bi-level. So a pressure of 20, pressure of 10, inspiratory, expiratory, and then on top of that superimpose high frequency breaths, as I described. That's high frequency percussive ventilation. It takes a little bit of expertise to turn the dials on this old looking ventilator. This is this ventilator. Dr. Bird, who's just a master on these types of ventilators, recently passed, but he was the inventor. Anyway, so this is the burn center at the ISR, has a long history of using this ventilator, and many burn centers use this too. And really, for me, the biggest benefit you get is internal chest PT. Because of that bidirectional flow from that percussion, the subtidal breaths, you see when you bronch these patients, secretions coming up the airway. So it's basically internal chest PT continuously. In a patient that is hypersecreting, that is unable to bring up those secretions on their own with the cilia that are decimated, it makes a lot of sense. And so we decided to look at this and compare it to ARDSNet, low tidal volume ventilation, because everybody was saying, oh, lung protection, low tidal 6 cc's per kilo, you need to do that on everybody. Even burns, it doesn't matter, extrapolated, even though none of them were enrolled in ARDSNet. And so we looked at it, in Dr. Wolf, and I looked at this, and it's something that, was one of the priorities in the early years during the war. And so this is a question we wanted to answer. So again, this was difficult to do, but less difficult because it was a single center study. We had control. We had, our research nurses are just fantastic. During this trial, I went on a 6-month deployment, came back, and had 10 more patients, for example, because just our infrastructure is just phenomenal. And so 62 randomized into 2 groups, 31 in each group. Low tidal volume, which is 6 cc's per kilo, versus high frequency. These are the demographics. About nearly half are combat injured, so that's why it's lower age. And then you can see about 40% had ARDS at the time they were randomized. Not all inhalation injury, as you can see. We took all comers. We want to look at, and then look at subgroups. And so this is the initial settings for high frequency. So peak inspiratory pressure 26 versus 6 cc's per kilo. And so our primary outcome was ventilator-free days. You can't use ventilator days because if you die at day 1, you have 0 ventilator days. and so that's a problem. And so we got to use ventilator-free days in the first 28 days. Same thing with mods-free days. And what we found was at 62 patients, we were rescuing a bunch of these patients who were on low tidal volume. And I'll explain that in a second. When you compare the two groups in terms of oxygenation, you see they get closer at day 7, but that's because in the low tidal volume arm, you're rescuing a third of them. You're putting them on a different mode because they're just not meeting oxygenation and ventilation goals. And so, so this is why that happens. But there's clearly a difference in oxygenation. But oxygenation alone is not a good endpoint in ARDS studies, as many of you may know. And so this is smoke inhalation injury patients. So of those, of the third that got rescued, it was mostly those that had inhalation injury that got rescued. And what does it mean to be rescued? Well, that means they're dying on their vent mode. They're not meeting oxygenation, ventilation goals. And so those that were not meeting criteria, they're not oxygenating, they're not ventilating, we needed to do something different. So we crossed them over, put them on high frequency percussive or APRV. Half of them got APRV as our rescue modality. We knew that the high-frequency percussive ventilator can cause damage to the airway, so we tracked ventilator and induced trachea bronchitis as well. And you can see of the rescue patients, they're all deranged. I mean, you're dealing with somebody that you just can't maintain. You can't keep going like this. And so we needed to rescue them. And so the conclusion is that our primary outcome was no different, and high-frequency percussive ventilator seems to oxygenate patients better, but more importantly, those in the conventional arm, when we tried to do 6 cc's per kilo, a third of them failed. If they had inhalation injury, 2/3 of them failed. And so what is the take-home message here? If you have a burn patient and you're putting them on mechanical ventilation, use whatever vent mode you want to meet oxygenation and ventilation goals. If you're using conventional ventilation, specifically low tidal volume, be prepared to fail 1 out of every 3 times. If they have inhalation injury on top of their burns, be prepared to fail 2 out of every 3 times. You better have a backup, or else you're going to run into trouble. That's the bottom line. Okay, so bottom line here is strict adherence to low tidal volume strategy using ARDSNet for everybody. One size does not fit all is extremely challenging in burns, and this is really the take-home message of the study. So really, for me, individualizing your vent strategy to the patient and their derangement is really the way to go. Okay. So how about ARDS? It's nice when a new definition comes out, because then you can validate that definition in the very unique burn population, and that's what we did. So we looked at the Berlin criteria compared to the American-European definition of ARDS, and as you may know, the Berlin criteria is, you got to have bilateral infiltrates, PF ratio less than 300 is mild, it used to be acute lung injury, less than 200 is moderate, and less than 100 is severe. And so we looked at this. About a third of patients who are mechanically ventilated develop ARDS. And as you go up in your categories, moderate and severe, this is the mortality. And so what's interesting is that mild ARDS doesn't seem to really be different than no ARDS, which is different from AKI. So, mild ARDS is okay, you can tolerate that. Most patients do okay. So how about severe ARDS? And so, that's a whole separate lecture of severe ARDS. I'm sure you've had speakers or teaching on this. And so I'd like to apply, this is based on randomized control trials, we're talking New England Journal level data. Lung protection, okay, don't abandon lung protection because I said, 6 cc's per kilo is challenging in burns. Try to apply the principles of lung protection regardless, and still as much as possible. I think I want to emphasize that. Paralysis, so using neuromuscular blockade early has been in randomized control trials to be helpful, found to be helpful. possible. Pruning, which means, this is the 4 Ps, so I got to use some word. So pruning means drying out patients, so putting them on a Lasix drip. If you need to put them on albumin, go ahead and do that. Push-pull thing that has been looked at in a randomized control trial, but dry them out as much as possible. And proning, so this is something that is difficult in burns, but not impossible. We've done it. But that's another intervention that's been proven in randomized control trials in severe ARDS to be helpful. And so these are the 4 Ps. Well, I'd like to introduce a 5th P, put on ECMO. I couldn't find something with ECMO, so I said put with ECMO. And so why ECMO and burns? That's ridiculous. Patients are going to bleed to death, and that was the common dogma back then. But we decided, we're an ICU supporting organ failure. We have lots of trauma patients, lots of sick patients. We need to start an ECMO program, so we did. We started an ECMO program. This is the experience of the burn community up to this point, and these are 2 studies that have been published just recently. And so this is from the ELSO registry, and you can see that not all patients that go on ECMO die. That used to be the thought. Like, if you're burned, you go on ECMO, you're going to die. And that's what Dr. Wolf used to say all the time. But you could see 43% survival in the ELSO registry, and this is the NBR, same thing. Probably a little same patients, but same thing. So 2 publications, and this is among our first patients. We actually, in this patient, lactate was increasing even on max 5 liters per minute of ECMO. And we're just not keeping up with his hypercatabolism. His cardiac output was 11, 12. And so, in ECMO, you're trying to match the blood flow of the circuit, and that's what determines oxygenation with the patient's cardiac output. And unless we put them on an esmolol drip, we're not going to be able to get there. You don't want to do that. Well, maybe. That's one strategy. But we decided to put a second circuit on. So this is double ECMO with CRT. Okay. So our experience in burns, you can see not all patients die. 60% survival. This is something that this just got accepted, so it's in the literature now in burns. For some reason, the Journal of Burn Care rejected this, but Dr. Wolf was kind enough to accept this. But you could see that not all patients die, which is patients can survive, and I've seen this firsthand. So I want to sort of shift gears. In terms of ICU care, we're evolving into this capability of providing organ support expands beyond just renal and lung support. And this is something that, as the critical care consultant for the military, for the Army, this is something a concept that I'm trying to, expand beyond the military, but also beyond. So MOST is multi-organ support therapy. And it's a concept that's been described for quite some time in Europe. It's, they've been writing about it since 2008. So, what other organs do you need to support? Well, there's the liver. There's patients that go into shock liver and they're metabolically deranged. And as I told you, we're trying to optimize the conditions of wound healing. Do you think the wounds are healing when the bilirubin's 30? I don't know. Nobody's ever actually demonstrated that, but I don't think so. You've seen patients who are, have bilirubins that high, who the wounds just don't look good. And so liver support is a concept that is starting to catch on. This is actually SPAD, or single pass albumin dialysis. You're putting a patient on an CVVHD or CVVH mode, and replacing whatever you're taking off. You're using, in fact, you're using dialysis that has albumin in it, and using the albumin to draw out bilirubin and other hepatotoxins. Okay, so you're leveraging albumin as an oncotic to establish an oncotic gradient. Very inefficient. It's better to do therapeutic plasma exchange. Okay, so this is a patient that we're doing therapeutic plasma exchange using a CRT machine. Just requires a different filter. Okay, larger pores to remove various hepatotoxins, to include bilirubin. You may be, you're crazy, Dr. Chung. No, this has been published in the literature, therapeutic plasma exchange for liver failure. And you can see out of the 31 patients for various hepatic failure conditions, this is toxic hepatitis, fulminant hepatic failure, probably shock liver, you know, there have been some that have criticized us for going into this territory because, oh yeah, you don't have a transplant center, so you can't do this. Why you can't bridge them to transplant? So what are you doing? Well, I would argue it's not a bridge, you know, to transplant. You could survive. You could support them through and survive. So it's not a bridge to nowhere. It's a bridge to recovery in a lot of patients. And so this, you know, this has evolved. So now there's something called MARS. I mean, this has been around for a while. But look at this. This is in Baltimore. They're starting to use this for liver support, the MARS molecular adsorbent recirculating system, which is sort of like single-pass albumin dialysis, but they recycle the albumin. So you don't have to, you know, deplete the entire hospital store with one treatment. You can recycle the albumin. And this is how they do efficient liver support, and Dr. Scalia and their group have done this and you know, reported pretty good outcomes, including trauma patients who have shock liver. Okay, so this is the paradigm now. You know, we're doing ECMO here, double CRT with plasma exchange, multi-organ support. This is a huge platform, and hopefully we are, you know, over time, hopefully this platform shrinks and we'll be able to do it with one machine. We're already very close to having a combined lung renal support device. So through the same machine, being able to do both CO2 removal, so low flow, and renal support, and that's something that the military is very interested in, and eventually we'll hopefully add liver and then do some sepsis therapy as well. So that's organ support, lots of exciting stuff. Nutrition, you know, obviously this is very, very important. Dr. Hansbrough emphasized this during his career. He's famous for that. But like I said, you're trying to optimize the conditions of wound healing. There's lots of, you know, data that suggests the hypercatabolism of burns is multi-fold higher than in most tissue destruction types of problems. When you compare major operation to trauma to major burn, you know, in terms of nitrogen excretion alone, is just no comparison. And so why not just overfeed them, give them more calories? Well, Dr. Wolf demonstrated that that doesn't work. You can't just feed, give them more calories. You got to exercise them simultaneously. But if you just overfeed them, that just deposits into fat. This is just fat mass, and you're not doing anything by just increasing the calories. And so that's so more calories equals increased fat mass, less lean body mass, and that's a concept everybody can get behind. And so. The burn community has been really advocating for various adjuncts. This is Inderol or propranolol for reversing the catabolic cascade. This is in kids, 60 kids in the New England Journal, Dr. Herndon's paper, and this is oxandrolone. We use oxandrolone regularly, and this is Dr. Wolf's multi-center trial that showed benefit, decrease in lean muscle mass loss, and decreased length of stay. Appropriate antibiotics, timely antibiotics is important, as you know. I'm not going to go into detail here, but you know, most patients who die after burn, it's because of an infectious complication. And so one of the things that we're encountering now is, you know, we're like the epicenter of multi-drug resistance. You guys are hearing about multi-drug resistance everywhere, but this is something that we've encountered over the last decade, and you know, we're up to 4 now that I have encountered personally, resistant to everything, even imipenem and colistin. I had a patient with colistin resistance with an MIC of 40. This is a problem. This is not a military unique problem. This is not a U.S. problem. This is a global health crisis. You know, this is why Margaret Chan, World Health Organization, said it's the end of modern medicine as we know it. You know, but there's hope on the horizon. I'm sorry, you know, I don't want to end right there. So there's actually, there's lots of efforts. Everybody's known that this was a problem that's been, that we needed to tackle, and so lots of money has been invested. DARPA has also been in the game. And DARPA, you may know, is it's called Defense Advanced Research Program Agency. So it's like the super secret organization that, kind of like the Space Force, So, anyway, so all of a sudden, one day, the government decided we need to make sure that we don't ever get defeated technologically. This is after Sputnik. We decided to form DARPA. If you are fans of Lost, it's kind of like that. So DARPA. Okay, so they have a program. This is for them, it's a small program, but it's, they provide seed funding for the internet. They provide seed funding for the Da Vinci robotic telesurgery. So they've done a lot of good stuff. So this is a program for DARPA. It's a $100 million program. But their strategy is they'll say, hey, we have a $100 million program. All of you apply for this program, and you get a bunch of applicants. Stop what you're doing. Here's $10 million, fix this problem, please, for the next 5 years. And so that's their strategy. And so they have this program called the DARPA Dialysis-like Therapeutics Program, and it's generated a ton of advances. And so this is the Harvard group, Dr. Ingber, the Weiss Institute, just remarkable if you ever have a chance to visit that group. And lots of things, lots of advances. So this is the hemopurifier, something that used to exist before the DARPA program, but they advanced their technology a little bit. And they're able to remove lots of viruses, and Ebola even. They reported a case during the Ebola crisis. There was a patient with a huge viral load for Ebola. They treated him on this filter and was able to reduce the viral load to almost zero after 3 days. This is removal of CRE, so circulating carbapenem-resistant Enterobacteriaceae, with another platform. This is Xtera, and this is really, I think, the most exciting development, development of a diagnostic to detect bacterial fragments, so PAMPs, bacterial fragments. And so how many times do you culture somebody who's sick and the culture is negative? You're like, oh man, most of the time. It's pretty unusual for you to get a positive blood culture, or, less than half the time you'll get a positive blood culture. It's because your body's already destroying the bacteria, and there's antibiotics already sort of mixed in. And so if you're able to detect bacterial fragments, that's pretty good. And if you're able to have a device that removes the bacterial fragments, you decrease the time that the patient and the host is exposed to that insult. And so again, the concept of decreasing the period that during that host response, that dysregulated host response. So this is the DARPA program has generated a lot of companies. So this is one company that existed before, but because of DARPA, they've advanced. This is a company that grew out of the DARPA program. Again, they have a diagnostic that detects bacterial fragments, and then they have a technology that removes it. So this is pretty exciting stuff. How about fungus? This fungus is something that we deal with all the time in the burn population. In this one study that we did demonstrated that most ICU patients die with fungus. They're immunosuppressed. They were going to die anyway. In burn patients, they can die because of fungus. So you need to be very aggressive about it. And so this is one way we categorize invasive fungal wound infection. We do biopsy, excisional biopsy, and if the fungus is present in the devitalized tissue, 1A, 1B, as it gets closer to the junction between devitalized tissue and vital tissue, it's 1C. We treat everybody who has a 1C. And then there's 2C, which is vascular invasion. And this is what the picture of that patient, this is aspergillus in the bloodstream. Just terrible. And so we've gotten pretty aggressive about empirically treating patients who we think are at risk. Although at the end of the day, I don't think any of that matters. Once patients develop a fungal infection, antifungals are not going to do the trick. They need the knife, something I've learned over time. And so, Cresemba is actually a drug that doesn't cause hepatotoxicity, doesn't cause renal toxicity, pretty well tolerated. So this is something that we started using, not prophylactically, empirically, in patients that we think are at high risk. I like to end with just, preventing complications. General good ICU care involves early mobilization, aggressive physical therapy. This is something that the burn community has led the way on. It's starting to trickle into other communities. Why is the trauma patient different than a burn patient? A burn patient gets an OT, PT every day, they get mobilized. Why can't you do that to a trauma patient? It's so unfair. I think you think it's unfair too, probably. Minimize polypharmacy. That's something that is a philosophy. VTE prophylaxis and moderate glucose control. These are all principles that can be applied in every patient population. And in the burn population in particular, this philosophy and these strategies are used to optimize the conditions of wound healing, and this is what we want. Thank you very much for your attention.
Jeannie, would you like to start with questions? Please stay put.
Oh, okay, yep. Happy to take any questions if you have them.
Do you have any questions? I had one, and I like to ask this of any person that comes to visit. What do you think is the next big thing on the horizon that burn surgery really needs to kind of get on the forefront of?
Well, I think it's the same as the last 3 or 4 decades. It's definitive wound coverage. That's the holy grail of burn care. It also needs to be complemented with technology that helps optimize debridement, because we know that you can achieve the holy grail, have the off-the-shelf skin substitute that's going to replace, normal skin without the need to create donor sites. But even if you have that product, you need a skilled burn surgeon who's experienced to know how deep to go, how to debride the wound bed. And so if you complement the Holy Grail with a technology that you'll be able to use to assess adequacy of burn wound excision, I think that combination is really going to change the game. Because right now, if you're a 90%er, you all know, the same donor site has to be harvested a dozen times, and then you got to use skin substitutes that are not necessarily that robust and permanent. Yes, epicells, but for deeper burns, it's not that, you're not going to have that much success. And so you're reliant on the patient to give you all the definitive skin. And so if you have something that's off the shelf, and we're very close, so we have something in the community right now, Stratagraft or Stratatect. Hopefully you guys can participate in the phase 3 trial. It's for deep partial thickness burns. It's not yet for full thickness. The next step is the full thickness skin substitute that hopefully will change the game. But this is, we've been talking, Dr. Hansbrough was talking about this decades ago. So, nothing new.
I have a question. There's been a recent initiative in times or eras where there's not much happening in military trauma to embed military trauma surgeons into civilian units for skills maintenance, et cetera.
Yes,
With the Brooke Army Hospital Burn Center, is there a similar need to do that with military surgeons for burn experiences, or can you accommodate all that you need there?
Yes, sir. That's a great question. I think you're already seeing the product of that with Balboa sending their surgical residents here. They used to come to the Army Burn Center, but because of cost issues, and we have residents coming from many different military facilities, and so that civilian-military partnership to get our military surgeons and other providers prepared for what they're going to see when they're deployed is vital. We all know that the military treatment facilities, if they rely just on the beneficiaries, who, by the way, all have TRICARE and can go out to get their care, that's one of the struggles that we're going through now. And so having our trainees, and even those that have graduated, come back and being able to rotate and get experience in civilian burn centers, I think that's a partnership that we're all working on. And I know COT is working on that, and burn community to some degree.
Other comments, thoughts? Well, Dr. Chung, thank you so much for being here.
It's some of the things that have happened for you in parallel with ourselves as well. Recently, we had our first trauma and our first general surgery patient survive ECMO, and we've also been very heavily utilizers of CRT, especially in patients with sepsis,
Right.
but also stabilized patients with ARDS as well.
Right.
And so there was a period back in the early 70s maybe was infamously remembered as the house of God, where all of a sudden these new interventions came along and patients could be made to survive what insults that were previously unsurvivable.
Right.
And now we have this. You have the advantage in your facility, however, of treating active duty soldiers, and the issue of palliation comes a little later.
Yep.
But how do you balance that? The ability to put a patient on 2 ECMOs,
Yeah.
2 CRT,
Yeah.
maybe Mars, versus the fact that the outcome here is maybe predetermined, or
Right.
and it's obviously different with the young soldier. I recall being in Afghanistan, being, expecting care on a young
Yeah.
soldier is one of the most difficult decisions you ever make in your life.
Right.
In a situation where you've got all these capabilities,
Yep.
yet you're dealing with a 50-50 proposition.
Right.
How do you guys decide when it's gone too far? What signs do you have?
Everybody reaches the point of no return, regardless of their age, and I think it's variable in terms of when the providers or the treatment team gets to the realization of that. But as long as there's signs of life, in my opinion, and there's reasonable hope for functional recovery, you go all out. That's our philosophy. And so that patient in double ECMO, he's 18. You're not going to give up on that guy. So, I think our approach would have been different if he was 80 and had cancer. I mean, there are clear, black and white patients, and then there's a bunch of gray, and that's where we come in, and we have to make that determination carefully and not. And in some places, like, resource-restricted healthcare systems, there are limits to what you can do and how long you can provide the therapy. For example, in Japan, you have 14 days of ECMO. That's it. You're done. Trial of 14 days, and if you're not off by 14 days, you're done. And have we continued patients and sustained their life in patients that probably won't have survived? Yeah. And we have cystic fibrosis patients that we put on. We have about 5 that we've done in the last 3 years, and 2 of them were not candidates for lung transplant. But they're talking to you, so these patients get extubated, so they're on ECMO, they're talking to you, they're not a candidate for lung transplant. And so in a very difficult case, we took a patient who had been on ECMO for 100 days with no hope for lung, and talked to them and walked them through the process, the dying process. And so, yes, there is a balance, and we have to be careful not to, throw the kitchen sink when things are hopeless and they've reached a point of no return. But everybody declares themselves at some point. But yes, you're right. We do have the capability to keep patients alive, sometimes to their detriment.
Okay. Photograph time. Thanks a lot, Gavin.
Yeah, thank you.